Thank you. Have a great day. Hi, everybody. My name is Michael Rosenfeld from Vatica Health. Thank you all for joining today. The topic we're here to discuss is partnering with PCPs to maximize compliant risk adjustment yield, which is an ongoing challenge for all of us collectively. And we hope we're going to help you today and learn a little bit more about how we've solved for it and not solved completely, but made a dent in it. Just to start off, is some housekeeping tips. If you do have questions, everybody's muted to protect your privacy. But if you do have a question in the event window in the panel's drop-down list, you would select Q&A and you type in your question in the box and hit send. We're open to you offering questions throughout the presentation, and hopefully we can get a chance to integrate that into the presentation today. There are also 3 polling questions that are going to come up. Our goal with that is to get to know you all better, to make sure that we can kind of cater some of the material to the type of audience that's on the phone here and understand some of the things that you're involved with relative to value-based care, what size plan you have, and what your engagement rates have been in terms of being able to get to PCPs in your own experience. So just to start off here in terms of an agenda, we're going to go through the profiles. I'm here with Dr. Brian Williams from Northeast Medical Group. He's going to go through a profile of their organization, then we'll give you an overview of Vatica Health. And then we're really going to dive into some of the dynamics that exist in terms of the challenges that are faced when you are trying to engage PCPs, whether it's technology, EMR integration, dealing with multiple payers coming to provider groups, dealing with employed versus community providers. All of us have dealt with the impact of B28 and how that's impacting providers and making sure that they're transitioning to that. And then we're going to go into some case studies and results. So with that, I'm going to turn it over to Dr. Williams to introduce himself and introduce NEMG.
Hey, everybody. Thank you so much for joining us. Brian Williams here. I am a PCP. That's what I do, primary care physician. I'm a family practice doctor in Mystic, Connecticut. I am part of Northeast Medical Group. I also serve as their medical director for clinical optimization and a medical informatics officer for Yale New Haven Health, which is our umbrella organization. But primarily what I do is primary care. And so, I think I have some perspective on this because I've kind of grown up in this world. Northeast Medical Group is a growing nonprofit multi-specialty medical group that was founded in 2010. It is the ambulatory multi-specialty group that's part of Yale New Haven Health. As of today, we have over 130 practice locations and more than 300 clinicians, of which 175 are directly employed. The balance are through service agreements of pre-existing groups, but they're essentially function like employees. We have a total of about 230,000 covered patient lives. In terms of shared savings agreements or cost sharing arrangements, we work with 7 Medicare Advantage plans and 4 commercial plans. Currently, all of our shared savings programs are upside risk, although that's partially due to the climate that occurred with the pandemic. We have a fairly mature ACO that was set to go into more of a shared risk model this year, but then that was backed off of because of the pandemic. And we have 4 different clinical documentation improvement programs across a total of 6 payers. So we've kind of seen the gamut of what those look like. And in terms of our involvement with Vatica, we currently have over 100 clinicians that work with them in a total of 28 different sites.
Great. And I'm Michael Rosenbaum. I'm VP of Business Development at Vatica. I've been here 4.5 years, but I've been in healthcare for 33. As far as Vatica is concerned, we've been around since 2011. And we are an organization that does prospective risk adjustment quality documentation. The uniqueness of our model is that we dedicate clinical staff with coding expertise to primary care physician offices. And that helps drive a more complete, accurate, and specific outcome, and also compliant outcome out of the whole process of this documentation. Right now, we're in 26 states. We have 5 national partners. We're really proud of the fact that we won the class award for 2023 for risk adjustment. And at the bottom here just references that we've experienced a lot of significant growth. I think due to the uniqueness of our model and our kind of high touch approach to this space. So as far as the current market dynamics, I think that we hear this from all of our customers and partners in terms of what are the things that really need to occur when it comes to engaging primary care physicians. One of the key things there is aligning reimbursement, in terms of from the top of the organization down to the front line, which includes not only the providers, but also the office staff in many cases, to really make sure that everybody's in sync and driving towards the same goal. With value-based care, it's very complex. And I think, if I look to our experience, the knowledge level in terms of being able to understand that is really across the board. And to the extent that you can create transparency and simplicity relative to that for the providers, I think that's only something that will really help things. As far as staff resources, it is a big challenge, right? Providers want to see patients. The administrative part of this is a have to do, but it's not their desire to have to staff up to do things like risk adjustment. And it's an ongoing challenge and a burden that I think they're looking to the payers and the health plans to help them with that process. And then lastly, and a really overriding thing that exists out there is the need for compliance across the board, and making sure that with all the scrutiny going on, you're buttoning up everything that you're doing, that you're protecting your organization, and you're protecting your providers.
So I'm just going to speak briefly to kind of how we envision an ideal process in terms of risk assessment for patients. Really because this is work that has to be done by a clinician. We stated this is a PCP centric. Largely PCPs do this, but any clinician can do kind of risk assessment. But I think the point here is that whatever solution we put in place, we want it to be providing the resources needed to the clinician doing this work so that they can do it effectively and kind of integrate it into their work. The better the system supports the clinician, the better job we're going to do in terms of assessing risk accurately, which is, leads to all the outcomes that you see listed here on the slide. Yeah. So, this slide begins to kind of speak to how we engage our providers in this work. So, specific to, I think, the Vatica solution, one of the things that they do very well is they have a provider engagement staff. They have people that are there to support clinicians. So HCC coding or risk assessment is new to clinicians. This isn't something that they've been doing for a long time. It's kind of new work. And specifically the knowledge set there isn't where, it is for many of the other things we do. And so having the right staff to support them is a very helpful thing. Clinicians all work differently. It is a very heterogeneous group. And so having flexible workflows that allow the clinicians to kind of do this in the way that works for them is important. So the clinical documentation, the way that we document, that's a really important piece of this, because if it's not done correctly, then the work is all for naught, as you're all aware. So having the right educational resources is a big deal. Then the last thing, aligning incentives, we're going to talk more about that, I think, in some depth, but that's a really important part of this, considering that we're trying to move away from the fee-for-service world. In terms of kind of technology, So leveraging the information that's out there in terms of supporting this work is really important. So PCP payer relationship is a big deal, but the clinical data that we can mine in the EHRs is also very important. Computer assisted coding, having that tech on the backside that can lay the groundwork for this work as we're beginning to understand what the conditions that need attention are, but then supplementing that with really good quality assurance review to make sure that the codes that are being presented to clinicians for risk assessment are high confidence codes. And the last thing that we see here on this slide is that we want the technology to be easy to use. I mean, I think that's pretty common sense. We don't want it to be clunky. We don't want this to be something that is, confusing for our clinicians. We can move on.
So as far as the different types of solutions that are out there, I think we're trying to capture the spectrum here of tech only, or things that are generated that produce suspects for providers to consider in a form or through some type of technology. Those that are EMR integrated, where it's presenting itself through the EMR, and then those that are kind of combining tech with people and resources, so that you're getting some type of filtering and some type of support system across the board. So as we look at the role of this technology, the idea is take something that's complex and make it easy. So, Dr. Williams referred to this: do not disrupt the workflow. And when the providers are seeing the patients, this should be something that should work within the workflow that they already have. Presenting high confidence conditions is critical. And Dr. Williams, I'd like you to weigh in here, because trusting, not having as much noise in putting a list of 25 things is going to create an aversion to actually even looking at the list. And Dr. Williams, if you could just weigh in on that and how that affects your view of things, that'd be great.
Well, clinicians, when they're working with patients, their attention is 100% focused on the patient. So when we're basically approaching a patient, and especially in a visit, what we call negotiating a visit agenda, we're trying to identify those conditions that are the most important, that really need our attention. If we've got technology that's presenting us with stuff that really isn't either accurate or isn't that necessarily that high in terms of importance for the patient's needs, that can be very disruptive to the work we do. So, the conditions that we consider high confidence are ones that we have very ample evidence for, and that are impactful to the patients.
Thank you. So as health plans and payers look at this space, and are trying to solve for this and drive this high engagement, that's a really critical piece that needs to be curated. And the other part is making sure that it's timely and actionable, and making sure that it's delivered to them in a place either before the visit or during the visit, where they actually can consider what you're offering them in a way that will impact the outcomes for the patient. And then ultimately, it should be accurate and complete, that completely capturing all the different codes, especially as we get into value-based care and where the provider has a stake. This is obviously critical, because they're going to want to get full credit for their work. One of the things that a few things that it shouldn't do is require them to go back and forth between their EMR and some other source. And it really, I guess this goes to the point of the high confidence conditions, contribute to alert fatigue. Providers get alerts all day long, and to the extent that you can limit that to things that again, as Dr. Williams pointed out, are high confidence, and don't hit them over the head with too many things, it's going to really drive engagement higher.
So I'm going to speak to this question: should the solution integrate with EMR? And the answer is yes. Yes, it should. So the EMR is where we spend our time. It's really where we exist. It's kind of a virtual reality for clinicians. And I'm assuming that everybody who's on this call, is kind of existing in a completely different space. But in the area of patient care, the EMR is our source of truth. They're big, they're complex beasts. They have a lot of parts. They have a lot of information. They can be difficult to navigate, but we all kind of learn our roadmap through them. It's sort of like living in New York City, but knowing where the best, like grocery store is and the best Italian restaurant in your neighborhood. Same way with EMRs. When we get information that is presented outside of the EMR, it's really of very little value to us. So if we're doing risk adjustment activity outside of the EMR, ultimately in terms of patient care, the impact is degraded. And I just want to point out that when we're talking about doing risk adjustment, what we're really talking about is making sure that we understand what the truly important conditions are that our patients have, and making sure that we're doing the right thing for them to prevent bad outcomes. It's really about patient care. Having this information integrated in the EMR is how that happens. So, the kind of the finer points of the slide, like how we do this, which EMRs we integrate with. There's a lot of nuances to that. It's complex because there's so many EMRs out there. But as time marches forward, the technology improves and our ability to integrate and only improves. The point here is that we do work in different ways at different times, but no matter what we do, we all want this work to end up back in the EMR. And we're talking to like supporting the triple aim, which I prefer to use the term quadruple aim, because we're not just trying to improve the patient experience, improve our population health, reduce our costs, but we're also trying to keep our clinicians from like losing their minds and leaving medicine, which is the fourth of the quadruple aim. So the reason that it's important, I think I've spoken to this partially, but the reason it's important to have this information in the EMR as much as possible is because that's where we work. That's our single stream of information. So having information integrated in EMR, you can talk about the clinical documentation support 5 rights, being you can read them off here, right information at the right time with the right person, right format, and right channel. But the point is that it's all there. It's there when you go to look for it. You know where to look for it. It's in stream. It makes it easier to use and access because we know our EMRs better than we know other tech. And it's at the point of care when we are doing that work. In terms of data integration, so a key part of this is getting the structured data from this work back into the electronic health record, right? The ICD-10 codes that we can put into our problem list, which for clinicians, that's kind of our to-do list. This is where we keep track of the things that need our attention. And getting those codes that are identified back into the problem list via structured data integration is a big deal. And then the last thing is if we're doing some kind of risk assessment and there's a document that is created by that risk assessment activity, as there must be, that also needs to be integrated back into the EMR for reference in the future. So this is this is almost kind of stating the super obvious. If every different payer has their own solution, that means that we, the people who are doing this, have to learn a bunch of different ways to do this. And I can tell you that on my desk right now, I've got like papers from at least 4 different approaches to clinical documentation improvement that are awaiting my attention. And of those, there's only one that's EMR integrated. The others are paper forms, which, they do accomplish what we're setting out to do, maybe not as effectively. But the point is that it takes a lot of extra work for me to go back and make sure that we're verifying that information in the EMR, that we have the right information, that I'm doing the right thing with the risk assessment. We don't like doing work that's not accurate. We really want the work that we do with our patients to be right. In terms of best approach, a single approach that kind of accomplishes the aims we set out is really the preferable thing.
So this is not going to be me trying to translate V28, because that would be a problem for all of you if you took what I say out of this, because I'm not an expert. But what I do know is that we collectively need to make the transition from V24 to V28 over these next 3 years a smooth one. And the way to do that for the providers And the way to do that is to really insulate them from all of this and basically make it seamless so that they're basically doing their work as they did before. Whatever changes that are happening from V24 to V28 are integrated into what you're putting in front of them, and they don't have to translate any of this, because if that's an expectation or if that's a requirement, it's going to create a huge problem, and you're going to end up with poorer results. So that's the point of showing this slide. So, oftentimes, and I'm sure as health plans, you're dealing in some of your provider-owned health plans, you're dealing with organizations or health systems that have their employee docs where they maintain control, and then they have their community providers, which are on multiple EMRs. They're a wide variation in terms of performance. And when you're engaging them as organizations, or whether it be through a health system itself or through an ACO or a CIN, trying to drive higher performance from these community providers is ultimately one of the biggest challenges that exist in terms of remediating poor performance and trying to reel them in. So that's an ongoing problem. And I think the key there is to, and this points to something Dr. Williams just pointed to, is if you're coming to them with EMR agnostic solutions where you're able to just serve them from where they are, create a support system of education, and to the extent that you can provide staff and other types of resources to help get them up to speed, that's where you're going to create a situation where you have uniform performance across the board, and you're going to drive consistent performance for the system itself. And I see from the polling results that a fair number of you are on value-based arrangements with your providers. A good percentage of you. So obviously there's a win-win opportunity here, and getting this group in control and driving high performance from this group is a critical piece for everyone's success.
So in a way, I wish we could open this up so that we could have a dialogue, because I have so many questions for all of you in terms of what your experience has been trying to engage your providers. I know that can be really variable. There's a lot of tricks that I think can make that more successful. From the perspective of the clinician who's delivering care, when we're asked to do some kind of risk assessment activity, it really helps to have a lot of that work, the clerical work, done beforehand, before it's presented to us. And that kind of falls in the category of do the work that you can do. Make sure that we're working as a team. The contributors who are part of that team should, do all of the work they can to prepare this for the clinician, so they can then, use their training in clinical decision making to actually do the assessment, which is the part that the clinician is required to do. And then the other thing is, if you go to, let's just take a community clinician as an example, and I say, hey, look, you need to do this additional risk assessment activity. And they say, so what's in it for me? You're going to say, well, it's going to really help your patient care and it's going to help our numbers. You're not going to get a good response. This is extra work over and above the stuff that we're already doing. And so really clinicians who live in a fee-for-service world, but don't want to, who really want to, I think the ideal is that we work in a world where we get paid for doing the right work, doing it effectively with the best outcomes. And for us to start that transition, we have to start, paying for some of this kind of work, which is really much more oriented towards population health. So you have to reimburse for the time and effort that they're spending on this. And then making sure that the clinicians who are doing this have the appropriate resources to help them learn how to do this correctly, and make sure that they can navigate whatever solution it is. Obviously, interrupting the work that we're doing at the time we're spending with our patient, making our revenue cycle less effective, burdening our staff with this stuff, that's not gonna pan out well. We already have a lot on our plate. It's really about kind of coming up with an effective team that can support this work in a way that makes it as efficient as possible for the PCPs. And the second part of this is, making sure that the clinicians doing this work know that the work is valuable and make sure that they're rewarded for doing that work. So I do believe that, when there is shared savings, when there's cost savings, when we get appropriate reimbursement for the right risk assessment, that, part of that belongs to the clinician who's doing the work, and they want to be paid fairly. They want to be paid quickly. We want to make sure that those patients that are getting these kind of risk assessment type activities done outside of the clinic, that it's not penalizing the PCP who's actually caring for the patient. And then the other thing is, the clinicians are the one who have to make the call on which conditions are actually accurate and what the assessment is. And we don't, it's not appropriate for other people to be making those calls for us. There's a lot of word out there about fraudulent risk assessment activities. I can tell you PCPs are going to want no part in that. They're not going to want to take the risk if they think that something isn't true and we're asked to stretch our credibility. It's not going to work well. Similarly, you can't carve us out of the care decisions. It can't be something that we're not, participating in. Similarly with patients also need to be kind of rolled into all of this. And then the last thing is, we're all staring in the face of the potential for reduced risk assessment kind of rewards with the shift to V28. And, it's going to be a losing proposition if we try and put the burden of this on the back of the PCPs to try and close that gap. That's just something that they're not in a position to do. So just to kind of speak briefly to Northeast Medical Group's experience in this arena, we have a very highly functional value team, we call it, which is the team that works in all of these kind of domains of risk assessment and shared savings and basically quality of care and population health. And it's really been our first toe in the water towards a true value-based healthcare system. I think we all understand that the fee-for-service system is kind of broke, that we really need to rethink the way that we deliver healthcare. And while I don't have the solution to how to make that transition, I am, a big supporter in making sure that we're paying more attention to the population health side of things. And this is a very good first step. Part of the success that we've had is that in all of those activities, we are sharing the organization savings with the clinicians. They understand that work is valuable. They take it seriously. We don't have to measure them. We don't have to force them. They do this because they know that it's valuable. They've also become very skilled at it because they've gotten very good education and support to do this work. Our HCC recapture rates for this year, I think, are for last year, for fiscal year 22, were over 93%. They were very high. And so the flip side of this is when we do this risk assessment, we're actually tracking our patients' relative risk scores. And we have essentially kind of categorized our patients in terms of overall risk into 7 categories. We understand very clearly what patients' risk for hospitalization and significant illness or death in the next year is based on which risk category that they fall into. And we have begun to use those risk categories to direct our resources. And we're seeing lower hospitalization rates for those patients that we're using this algorithm for. That's pretty encouraging. I mean, that's really the whole reason for doing this, right? We have several different, I mentioned earlier, payer programs in place. Vatica has the highest participation. It also has the highest user satisfaction. It's a really effective program. And the big deal is that it's integrated in our electronic health record, and that information that we generate becomes part of the patient's care going forward. And, personal experiences in multiple cases, the folks that Vatica has that are helping with this initial review before the data is presented to the clinicians, they have identified conditions for patients of mine that were not on the radar. And I see this and I see the evidence and I go back and I'm like, well, this is something we need to pay attention to. That's a big deal. I mean, I don't care how good your clinicians are, they cannot see everything. And so kind of surfacing those conditions that are important but may have been buried in the mountain of information is a really big plus in this situation.
So along those lines, we just thought we would share a couple of KPIs and a few case studies as far as some of the work that Vatica is doing. Dr. Williams pointed something out. I mentioned in the beginning, Vatica's model is one where we combine technology with people. Those people with technology, before the patient comes in, do a deep dive in the EMR into some of both the structured and the unstructured data. And those nuggets that Dr. Williams was referring to are captured by the people and the technology together, extracting that information and then presenting it to these providers in an easy to understand way at the point of care so that they can address these conditions and document them. With Vatica right now, we're seeing 75% of a provider's panel in a given year. I saw some of the engagement rates amongst those that are on the webinar here today. So if a provider has 100 patients, we're getting 75% of them in for what we call a Vatica visit, which is a complete coding and documentation exercise that takes around 2 minutes, one time per year. Overall, we're getting to around an increase of 25% in terms of the accuracy and specificity improvement year over year. We're also closing care gaps on behalf of our providers and supporting that whole process. Our average is around 37%. And then really importantly, on the bottom left here is that we have an advanced coding team that reviews 100% of everything that gets documented by the providers to make sure that it meets CMS standards for clinical validation. So nothing actually gets back to our payer partners, our provider partners, that hasn't been reviewed in that multi-step process to make sure that it meets the standards for compliance and protects them from audit. So here are a few case studies. This is a group, this is a regional blues plan. They have around 100,000 members. We've got 80,000 of those members under contracts. The way Vatica works is a health plan hires us and then they identify a subset of their provider group typically for us to work with. And then we actually contract with them in a payer agnostic way. So if I look at this group, it's in Northeast region, we have 7 different payers that we work with in the region where this health plan is. When we're going to a group like Dr. Williams' group as an example in Connecticut, our contract with them is a payer agnostic contract. So we're able to serve all the different payers that are sponsoring them, and that drives higher provider engagement. In this case, we're getting to around 81% of them. And then you can see over time here at the bottom, the percentage of the population that we've been able to get to year over year as those numbers have increased, and the translation of that in terms of the encounters and the translation of that into the value that they, that this plan has been able to see is significant. And then lastly, this is a group in New York. Dr. Prosky, I think for those of you that have attended RISE events, has spoken at a number of different RISE events. She's a really dynamic and fun speaker. This is our work with their group, where we've gotten around 73% of their patients, which are around 47,000. We've closed 73,000 care gaps for them. We've improved their diabetes specificity, which I realize over time is going to be less important. But I just want to point to her comments here and just highlight that, because this is really at the heart. I mean, we typically are hired by health plans, but we are a very provider-centric organization. We care about making sure that their job is easier, which then translates into value for everybody who has a stake in it. Her comment is that our team is always with her, and we're there ongoing. So we're very responsive and very kind of white glove in terms of our support of the providers that we work with. So that's where I'll leave it today. I see there's some questions on here, so we could start to answer some of those. And please, ask questions. At this point, we'll open it up to Q&A. I do want to point out that at the end of this, there's going to be a brief survey if you wouldn't mind sticking around. We're short on time in terms of, we're actually long on time in terms of the fact that we're probably going to end early here. So if you would stick around and answer the survey, our team and RISE would greatly appreciate it. So the first question here is, do specialists follow risk adjustment methodology?
So I'll take that. In our group, all of our clinicians are educated in terms of risk adjustment, meaning basically the assessment process for the high value or HCC codes, and they do all participate. We get a quality scorecard monthly that includes the percentage of those codes that have been recaptured in a given year. and our specialists do pay attention to that. They don't participate directly with the Vatica visits for the simple reason that being specialists, they're only responsible for a subset of the codes that would be part of that type of assessment. But they do, but they are part of the quality adjustment for our patients.
Great, thank you. So the next question is, how do patients respond to the need for that Vatica visit that takes 2 minutes? Are you incenting them to cover travel and other costs? Do you perform them year round, or do you wait till later in the year when gaps haven't been closed? The 2 minutes that they're spending is tied to an incentive. So typically the health plans that we work with are averaging an incentive around $150 in exchange for that 2 minutes. When we're working with large healthcare organizations, that doesn't necessarily all filter down, but most of the organizations that we work with and those that are more successful filter a decent portion of that down to make sure that the translation of that time they're spending to the value that they're getting is worth it. The question about travel and other costs, there really isn't any travel. They're doing this on our platform, typically as Dr. Williams' group is doing, in the EMR. So they're able to really do this work in a very efficient way. We do these all year round. And we attach our visits to both, not both, to annual wellness visits, physicals, and any other substantive visit. And we basically are driving a lot of value by doing that. And for those plans that are looking to get bids in, there's tremendous value in getting this information earlier in the year so that your bids are more accurate later in the year.
Yeah. Just to piggyback on that, the question is specifically saying, how do patients respond to the need for these visits? So it's transparent to patients. Basically, we cleverly in primary care try and bundle as much stuff into single visits as we can. Specifically with wellness visit, that's the kind of visit that this marries with the best. A wellness visit, I don't know how well you guys know this stuff, but a wellness visit is essentially a risk assessment and preventive health focused visit. It doesn't have anything to do with the actual active care for patients. But in primary care, the kind of emerging best practice is to marry that with another visit, depending on the type of Medicare the patient has, that addresses the patient's ongoing chronic needs. And then we kind of piggyback that Vatica visit into that as part of that as well, because we're essentially addressing all of those same conditions. The best case scenario is that what we're doing for the patients during that kind of combined visit also addresses everything that we need for the Vatica visit.
Great, thank you, Dr. Williams. So this last question, Dr. Williams, you can't see these questions, correct? Or can you?
Yeah.
Okay. I think this is more appropriate for you than for me.
I'm going to go ahead and read it out loud if that's okay. So how do you balance staying in your lane with working at the top of your credentials when it comes to accurate coding? We have struggled when communicating with our providers about this because we want to let the certified coders work through what is supported by the documentation, but we also have pushback from leaders about the provider time and burden needed to confer with the certified coder on potential changes. How do you find communicating a balance here? We want to insulate the provider, but also don't want to have certified coders making changes without input from the providers. So yes, this is a tough one. The thing is that there's different ways to approach this. If you get a visit that is coded in a way that it's missing important diagnoses for the patient, or that certain diagnoses are coded incorrectly, that really comes under the umbrella of clinical documentation improvement. And having an effective kind of formal process for how that works, I think, is important. And a big part of that is the umbrella education, where you can sort of track and trend these things, which we kind of do with our billing service. But I feel like the best way to approach this is to be proactive. In other words, present this information before or at the time of visit rather than retroactively. So, I think one of the key things here, and I'm not just like, leaning on Vatica the way they do it, but it's a very good example. When we have our wellness visits, their staff has already gone through and done this work ahead of the visit so that they have not only conditions that have been identified that may be applicable to the patient, but also the evidence supports them. So when that's presented to the clinician, it's very easy to validate or to decide that isn't applicable to the patient. because we have all that evidence there. It's harder to do when you're working with coders because by the nature of their work, they have to do this retrospectively. And that, the best I can tell you is that in our experience, a robust kind of CDI program that uses coders not only involves kind of ad hoc communication with clinicians, but it also involves kind of understanding trends of conditions that aren't getting the um, attention that they need, and then providing education to the provider cohort as a whole around those things, which we've had to do with HCC coding. We've been working on this. We've been hammering on HCC coding for years. It's taken us a long time to get to where we are. But then also for individual clinicians, if you see trends for them, then providing them that extra support. The key here is always going to be in reimbursement, though, because if clinicians are missing conditions, they're probably also undercoding, and getting them to, understand how they're approaching this and then coding correctly is probably your lever. And also, yes, it's not as easy as just saying that. I understand that.
Great. So that's the questions we have. We really, really appreciate you taking the time. Hopefully this was valuable for all of you in terms of learning, especially from Dr. Williams, hearing firsthand how they view it from the provider side. And we appreciate your time. There's a survey that has just popped up, so if you would mind filling that out. And we appreciate your time. And Namita, I see your question. I will reach out to you directly. I don't want to hold up the rest of the group. And we'll get that answer to you directly. So thank you all for your time. Kayla, I don't know if there's anything else that you want to cover before we close this out.
Nope, we're all good. Thanks, guys.
Okay, thank you all. Have a great day.
Thanks, everybody.